is the turn about the endocrinology part 2. And today is Sunday, 27th, 8 o'clock. So thank you, Joe, for to be part of the group today.
Thank
So
you.
let's start. So here we have the thyroid gland. So and I put this picture. This is actually a specimen of the thyroid gland. And the thyroid gland, I would like just to have some few things that probably are going to be interested, is that the thyroid gland start to form about 3 to 4 weeks of gestation. The thyroid gland start, they're going to be is the first endocrine gland that is going to be formed in the systems, in all the systems. And mostly are located under the tongue. After that, the thyroid gland starts to descend down to the trachea, in front of the trachea, and that is going to be about 8 to 7 weeks of gestation. And this is about 18 weeks of gestation, the patient or the person start to produce T3 and T4 for the first time. You can see here that the adult size of the thyroid gland is going to be reached about 15 years old, And the dimensions of the thyroid gland is going to be about 6 centimeters, 5 centimeters, 6 centimeters, 4 centimeters, and deep about 2 centimeters. We have here two main portions of the thyroid gland. We have the lobes, the right and the left lobe, and here in between what we have is the isthmus. This isthmus is the one who is being measured during ultrasound in order to see if the thyroid gland overall is being increased in size, what we call goiter. All right, so this thyroid gland, let me here. So here we have the lobes of the thyroid gland. This is posterior view. Thyroid gland is the word means shield because it looks like a shield. And this where is located the thyroid gland? The thyroid gland will be located under what we call the larynx. Well, commonly they call the Adam's apple, and it's about 1 to 2 fingers below the inferior border of the thyroid cartilage. So this is the thyroid cartilage. Here's some another, the cricoid and the arytenoids, whatever, but it's always below the Adam's apple or the thyroid cartilage. So we have what is important to see in order to understand or make it easy to understand the physiology is that the thyroid lobes are going to be formed by few things that we are going to see in the next slides. So we have the thyroid glands. The thyroid lobes, right and left, are connected by the midline that is the isthmus. Here we have some anatomy location. So we have here the sternocleidomastoid with the two insertions here, clavicle, sternum, and the mastoid process. And under these, we have other muscles that are going to be the omohyoid, sternohyoid, sternothyroid. So they are going to be just here the thyroid cartilage, and under the thyroid cartilage, we are going to have 2 to 3 fingers down is going to be the thyroid gland. The thyroid gland is being over the trachea. This is the trachea. The trachea is central, and the trachea is having about 15 ring cartilages. And the thyroid gland is going to be located in the between the third and the fourth and the fifth cartilage of the trachea. All right, so let's continue. Here is just another view about the thyroid cartilage. This is the trachea. So we are going to see that the thyroid gland is going to be located just here over the trachea. It's not covering the thyroid cartilage. It's going to be under these few rings, the first rings of the trachea. All right, so let's start. Here we have, this is a nice anatomy of the thyroid gland. here we have the location. So if we see here, this is the carotid arteries, the internal carotid artery and the internal carotid artery that are side by side of the thyroid gland. This is the trachea, jugular veins with brachiocephalic veins that form the superior vena cava. Here we have another nerve that is the vagus nerve that is going to give the recurrent laryngeal nerve that is for the voice. Anyhow, so here's all the structures that are surrounding the thyroid gland. So mainly are the internal carotid artery, because the common is here, is below, is a little bit lower. So the internal carotid artery and more lateral are the internal jugular veins. Okay, so let's keep going talking about we were talking about the lobes, and the lobes are going to be formed by follicles, So if we have a piece of the thyroid gland, a we see under the microscope, this microscope is about 100 times augmentation. This one on the bottom, and here we have that these follicles are going to be formed by something. These cubical or cube cells are called the follicular cells. Inside, they're going to be like a swimming pool. Here's like a swimming pool, and inside, this is the basal portion. This is the apical portion. Basal is close to the vessels, to the blood. So basal, B as in basal, B as in blood. So this is the basal layer, and this is the opposite, the apical. So here they're going to secrete what we call the colloid, and all this together is called the follicle. The follicle also. All this is follicle, composed by follicular cells and the colloid. This is important because that is how we are going to understand the formation of T3 and T4. Okay, so here we can see that one of the first things that we need to remember is that the thyroglobulin, because globulin is a protein. This thyroglobulin is a protein produced by the follicular cells, and they are going to form inside the cytoplasm of the follicular cells, and then this thyroglobulin is going to be through exocytosis, they're going to drain, or they're going to go into the colloid. Colloid is a substance that is a little bit more than fluid, and the thyroglobulin is going to wait for the iodine that is going to be formed, and you know iodine is needed to form T3 and T4. Okay, so more here. So we have the thyrocolloid is a gelatinous product of the thyroid gland that is consisted mainly by the TG, the thyroglobulin protein, and these cells are the nucleus with each cell. They are going to send the thyroglobulin into the colloid substance. So we have the thyroid follicle. So we have one thyroid follicle here, another follicle here, another follicle here, another follicle here. Let's talk about the parafollicular cells. The parafollicular cells, called the C cells, are cells in the thyroid gland that are produced and secrete, they are going to secrete calcitonin. If we remember, the thyroid gland secrete the T3, the T4, the reverse T3, and they are going to secrete the calcitonin. So we have the reverse T3 is not really a functional hormone. We don't know what is the use of the reverse T3, and we are going to talk about the T3 and T4. All right, and the calcitonin. So if you see here, this is one follicle. The T3 and T4 are going to be formed here in the colloid. Let's put it this way, in the swimming pool. Meantime, the parafollicular cells are called parafollicular cells because are parallel to the follicles. So they are outside and in between the the follicles. So this is one follicle, one follicle. These cells are going to be the parafollicular cells that produce the calcitonin. We remember very well that the calcitonin is not linked to the hypothalamus pituitary thyroid gland axis. So it's going to be secreted according to the levels of calcium in blood. All right, so here we have again the parafollicular cells. And here we have an augmentation about 100x. And here is some trabecular tissue with fibrous tissue in between that are going to give the shape of the thyroid gland. Here we have some vessels. By the way, the thyroid gland is the endocrine gland that is the highest with blood supply. So the highest blood supply in the whole system, whole body, is going to be the thyroid gland. Okay, so more of this. So we have here, for example, nucleus, the cell, the follicular cells. They are going to be like one after another, and in the center are going to form the colon. So we just said that the thyroglobulin, that is a protein produced by the follicular cells, are going to be drained into the colon. All right, so let's talk about the type of thyroid hormone we have. We have the total T4, a total T3, free T4, and free T3. So besides the values that probably in the lab they are going to tell you elevated or low, we have that the most abundant is going to be the T4. Less abundant is going to be T3. So T4 and T3 measured by lab tests. T4 is at the level of the micrograms, and T3 is going to be at the level of nanograms. So it's very less quantity. So what we need just to remember is that I put free here because it's the free T3 is the one who is going to be active. So total T4, total T3, total T4 are actually values, but the one who is targeting the organ, who is targeting the to make action in the target organ, is going to be the free T3. So here we have what are actually the main functions of the thyroid gland hormones. Are going to be increase the metabolism. Increase the metabolism implies that the body is going to require more oxygen. It's going to consume more oxygen. Then we have the increase of proteins. So when we say the increase of protein synthesis, that means that this T3 actually what it's doing is to go into the nucleus of the cell and make the production of certain proteins or enzymes. So that is going to increase what is that is anabolism, because it's going to be mostly partially anabolic or partially catabolic, the functions of the T3 and T4 as we are going to see now. One of the things that is the body temperature control is one of the three main functions of the thyroid gland. All right, so another thing is that calcitonin is another the other hormone that is going to regulate the concentration of calcium in blood. All right, so let's start. Iodine is we have iodine and iodine. This iodine is the one who is going to link with the thyroglobulin in order to produce the MIT, as we are going to see in the next slides. So first of all, they are going to have an organification of the iodine. So we have the ioid that is going to be pumped into the follicular cells. We have the follicular cells that are going to receive the iodide, and the iodide is going to be passing through the peroxidase, that is peroxide, that are going to change from iodide into iodine. Iodine is a molecule here of two iods together. All right, so then what happened is that iodine is, when the iod enters into the follicular cell, inside the follicular cell find this peroxide. Inside the follicular cell, they are going to form the iodine. This iodine in the cytoplasm of the follicular cell then is going to be, through exocytosis, going into the colloid. So this iodine is going to find the thyroglobulin that we mentioned at the beginning. The thyroglobulin is produced by the follicular cells, and this is then by exocytosis go to the colloid. So at the end, the iodine and the thyroglobulin are going to find each other in the colloid substance. When they go into the colloid substance, they are going to form the MIT, the monoiodotyrosine. This M means because they have one molecule of iodine. So if you have that is what is happening here. So we have M. If they find, they are going to link MIT, that is monoiodine. Monoiodine plus monoiodine is going to lead into diiodotyrosine. Then we have that this, for example, DIT plus MIT means two iodines plus one iodine is going to be T3, is what is going to form T3. If they find in the colloid two of these DIT plus DIT, they are going to form the T4. Okay, so here we have, so the oxidative coupling is going to be again for another peroxidase, and this peroxidase is going to be in the colloid membrane, in the colloid substance. So one thing I just want to mention here is, for example, we have the PTU and the MMZ, PTU and MMC, and those are, for example, when you have hyperthyroidism, the propionthiouracil or the metamizole, those are actually that are going to block the organification of the entry of the iodine to produce MIT and DIT. So this is the level where the anti-thyroid treatment are going to make effect. Another is at the level of the coupling. And the coupling, as we already mentioned, is the, for example, DIT plus MIT is T3, or DIT plus DIT is going to be T4. All right, so this is what we was mentioning. This is the coupling, MIT plus DIT, T3, and if there is DIT and DIT, it's going to be T4. Okay, so here we have, then it's going to happen. Remember, we are in the colloid, right? In the colloid, we already have the MIT and DIT, and they are going to be T3 and T4. So all the combinations that you can have. This is happening after the thyroglobulin find a link with the iodine into the colloid. So form the MIT. This is like the brick. Two bricks of this DIT. So one of these plus this T3 and two of these T4. So these guys are going to be located in the colloid. Then what happened? They are going to pass from the colloid into the follicular cytoplasm, the follicular cells cytoplasm. In the follicular, inside the follicular cells of the cytoplasm, there is going to be some enzymes that are going to digest the protein, the thyroglobulin, and they are going to release T3 and T4. Now, this is ready to go outside of the gland. They are going to be absorbed by the high vascularization that the thyroid gland has around, and that is about. So, but the MIT and the DIT, they are not going to be out. So remember, in the colloid, all these guys are going to pass into the into the cytoplasm of the follicular cell. And then these, the ones who are coming out, T3 and T4, but the ones, MIT and DIT, are not secreted. They are going to stay. They are going to remove the iodine, and they are going to revert it again into the colloid in order to recycle the iodine again. So here we have, I created some short cartoon here. This is representing the follicular cells, and this is the iodine that could be coming from the diet, could be from diet, or could be mineral, like a source of elemental iodine, and they are going to be here the follicular cells. What happened now is, and here is the colloid. So this is going to be the colloid representation of the follicular cell portion. Then what happened is going to be the thyroglobulin. Thyroglobulin is produced by the follicular cell. This thyroglobulin is then going into the colloid and waiting for something here that is going to happen. We are going to have the elemental iodide. They are going to mix with the peroxidase, that is H2O2, and they are going to lead into iodine elemental molecule of iodine, that is I2. So what happened then is the iodine is going to go into enter into the colloid. They are going to form what we call the MIT, the mono iodide tyrosinase, or tyronine, sorry, MIT. Then appears many MITs, and when that happens, MIT plus MIT, DIT. DIT plus MIT, T3. DIT plus DIT is T4. And that is what is going to happen. So now we just mentioned that all these elements, the iodine and thyroglobulin, they are going to just be found here in the colloid. And the DIT, and we have here we have T3 and the T4 are in the colloid. So all these guys, MIT, DIT, T3 and T4, what they are going to do is they are going to go into the follicular cell. In the follicular cell, then is going to just go out into the circulatory system. All right, so that is about the formation. So just remember, we have the organization and the coupling, oxidative coupling, that are the ones who actually are important components of the formation of T3 and T4. All right, so we have target organs, and here is very interesting, is about that one thing. So we already talked that that the T3 and T4, the T3 is the most potent. T3 is the most potent, but last is the one who lasts shorter. T4 is the more abundant in the level of micrograms, and they are going to have a very long half-life time. Half-life time, that is going to be about, so this T4 in the circulatory system can last about a week. Meantime, the T3 is going to be about 1 day. The one who is binding mostly to a protein that is called the TBG, thyroxine binding globulin. Okay, that is not the thyroglobulin. It's totally different. This is in the blood. We have the thyroxine binding globulin. These TBG are going to be associated with the T4 and T3. 99% of T3 and T4 are binding to this protein, but only the free T3 is the one who is going to make effect. So why do we have T4? Why? Because T4, when they reach the cell, do not have any activity. They are going to, inside the cell, lose one of the iodine and produce T3. And is the T3 again the one who is going to make effect into the cell. So here we have, one thing I want to say here is about women who are taking for OCP. OCP is oral contraceptive pills, or women who are receiving some estrogen, or women in fertile age. These persons are going to need more when they are, for example, they have hypothyroidism, they need to receive thyroid hormones. So that means that they are low in T3 and T4, they need more T3 and T4, so they take the pills. For example, the Cytomel. Cytomel is actually T3 and T4. So what happened? They need higher doses. Why? Because women are having high levels of estrogen, and having high levels of estrogen. Estrogen is an anabolic hormone. This anabolic hormone make production of more proteins in blood. So if you have more proteins in blood, there is more binding, means less free T3 and T4 in the serum. So that is one of the situations that in clinical we always try to be aware. All right, so we have hypothalamus. So just something that we this is a review only. Hypothalamus, what is going to do is release the TRH, thyrotropin releasing hormone, and they are going to send it to the pituitary gland, and is the pituitary gland who produce the TSH. The TSH then binds the receptors of the thyroid gland, and the TSH, what is doing in very few words, is the more TSH you have, the more binding of the iodine, the more iodine is going to pass towards the follicular cell. So that is going to be transporter, actually what we call symport or co-transporter with the sodium. So the more TSH, the more capture of iodine into the follicular cells. All right. So high T3 and T4 is actually the negative feedback for the hypothalamus. So you have too much T3 and T4, the hypothalamus is going to just go, is going to decrease the stimulation. Potency is 3 to 4 times. The T3 is more potent than the T4. So here we have just in the PowerPoint we have the summary of all what we just mentioned. All right, so here we have the actions of the thyroid hormones. We have the basal metabolism, increase the oxygen respiration. They are not going to increase the metabolic rate for the brain, gonads, or spleen. For example, this is actually take it from the previous outlines of the previous lecture. Therefore, they are going to increase the needs for ATP. So, what is doing the increase of T3 and T4? Number one is start to increase the number of mitochondria into the cells, and they are going to. Why? Because you have more need of oxygen to create ATPs. They are going to increase the cardiac output. The cardiac output is going to be, if you know the if you have more T3 and T4, they're going to increase the heart rate. If they increase the heart rate with the volume, are going to increase the cardiac output. And the cardiac output increase means that it's going to increase the blood pressure. So obviously, if you have cellular respiration increase, your need of ventilation rate is going to increase, so your respiratory rate will go up. It's going to increase the glucose absorption. So they are going to increase the absorption and the production of glucose through the glucogenolysis from the liver and muscles that produce, from glycogen produce glucose, and the gluconeogenesis. So more increase of glucose here. The gluconeogenesis is the formation of glucose from other sources that are, for example, proteins, for example. Lipolysis. The lipolysis is going to be increased with the T3 and T4. So before, if we remember like a couple decades ago, they was using thyroid hormones in order to make a regimen to lose weight. that was OTC even. Then they took it out because they can have serious side effects. So the lipolysis take the triglycerides into fatty acids. So fatty acids is is available, and these fatty acids can be source of energy. So the glucose is going to be spared. So in any way, so glucose absorption increase, the glucose is going serum in blood increase, and the glucose is going to be even spared because you have high amount of fatty acids that can lead into energy. Protein synthesis, and here we have some deficiency of the thyroid gland. We have restrict bone and development. Cretinism is when the mother do have do not have enough iodine in diet, so the baby cannot produce his own T3 and T4 because the T3 T4 is going to be for the mother, and the own T3 T4 need to be produced by the fetus. So as you see here, this is going to be delay the development and growth of the baby and produce mental retardation. So at the end, it's going to produce mental retardation. Thyroid hormone works synergically with the growth hormone and somatomidine to promote the bone formation. So here we have serum, for just to have an idea, serum of T4 is micrograms. Meantime, is 1,000 times smaller. The T3 is in the level of nanograms. Okay, so here we have the when you have too much T3 and T4, what they are doing is they are going to be in the catabolic state. It's going to be catabolic state. So between catabolic and anabolic, when you have elevation of high levels of T3 and T4, they are going to be more catabolic. So they are going to have this, for example, a loss of weight. They are going to produce more ATPs. The temperature of our body is how the machinery of all the cells are working. So all is like we have some machine working of a car, for example, the engine, and the engine release some heat. The same thing happened with our body. Okay, so here we already finished with the thyroid gland, and we are going to continue with the adrenal glands. So these adrenal glands are actually the real specimen of the adrenal glands. They are located in the upper border or upper superior surface of the kidneys. We have a pair. The pyramid is more the right is more a pyramid shape, and the left is more globular, like a moon, half moon shape. Okay, so to know about the adrenal gland, we need just to remember that we have, if we cut in half the adrenal gland, we are going to have this situation. We have the cortex and we have the medulla. The cortex is divided in the zona glomerulosa that is going to produce the aldosterone. The zona fasciculata, the cortisol, and the zona reticularis, the sex hormones. So all these guys, aldosterone, cortisol, and here we have sex hormones in the reticularis, are hormones that are being needed to create from cholesterol. Cholesterol is the main, let's put it here, ingredient in order to produce aldosterone, cortisol, and androgens. So it's different because if we remember, we have two groups of hormones, the one who is from proteins, amino acids, and the other group is from cholesterol. These are the ones from cholesterol. All right, so what is doing this? We have the hypothalamus that is going to release the CRH, the corticotropin release hormone, are going to stimulate the adenohypophysis, and ACTH is going to be released to the adrenal gland. So one thing, we already know that the ACTH go to the adrenal gland to produce what? Cortisol only? No, they are going to produce the release of sex hormones, release of aldosterone, and cortisol. But for another side, we remember that we have the kidneys, and the kidneys, they have the renin, and the renin is going to have the same effect. So what is the difference, and what is mostly predominantly happening when you are, for example, you have low blood pressure, or you're losing blood? That is most commonly happen in other situations like metabolic disorders of the glands. So what the answer is, that the ACTH is going to, yes, it's going to produce all these hormones, aldosterone, cortisol, and sex hormones, but the cortisol is the has the highest sensitivity to the ACTH. So even though that ACTH have little effect of aldosterone, little effect on the sex hormones, actually they are going to have some minimal effect. Meantime, the renin is going to be specifically, almost specifically, going to have the release of aldosterone. So that is actually the difference. All right, so cortisol, what it's doing here is a glucocorticoid. Why? Because glucocorticoid, glucose, corticoid, cortex of the adrenal gland. It's called the stress hormone, and they have the circadian rhythm. The circadian rhythm of the cortisol is mostly in the morning, and it's going to decrease at night. So is the diabetogenic. Why? Because they are going to increase the serum glucose in blood, and through that gluconeogenesis. So have a very potent anti-inflammatory effect. Of course, we need inflammation in order to heal wounds, so they're going to presence of high levels of cortisol, the wound healing is going to be delayed. All right, so aldosterone, we already know that they are going to reabsorb sodium high quantity from the convolute tubules and exchange of potassium. That is going to be involved in the RAS. RAS, I forgot to put one more A here, is the renin-angiotensin-aldosterone system. And that is what is going to happen. Renin, some books they call as a hormone, some books they call as an enzyme. I stay as an enzyme that is going to act into the angiotensinogen in the liver to produce angiotensin 1. Angiotensin 1, they go into the lungs, and here we have the ACE enzyme, angiotensin converting enzyme, that is going to lead into angiotensin 2. This angiotensin 1, angiotensin 2, they have already some vasoconstriction, can produce vasoconstriction of the vessels. They already can lead into increase the blood pressure. Then the pathway continue to the angiotensin 2, they go to the adrenal gland, and they are going to go into the aldosterone, produce aldosterone. So this aldosterone indirectly is going to affect the heart. Why? Because the adrenocorticotropin factor that we talked in the previous slides, the previous lectures. So one thing here is that I want just to remark here is we have aldosterone, cortisol, estrogen, estradiol, testosterone, androstenedione. So all these are sex hormones. This is the cortisol, aldosterone, and everything here we have progesterone, and all these hormones are coming from the cholesterol. So that is the origin of all these glands. So here we have a real specimen of pancreas. The pancreas is about 12 centimeters long. It's about 1 inch height, and it's going to be about 1 to 2 centimeters thick. Is going to be located in the epigastrium, partially in the retroperitoneum, especially the head and the tail of the head and tail are mostly intraperitoneal part of the pancreas. And we have two main things: the alpha, the glucagon, and the beta, the insulin. Here we have the this is I always say that this is like a gelatin, and we have grapes. The grapes are the islets of Langerhans. These layers of Langerhans, they have different cells. We have the alpha, beta, delta, and the PP that is not mentioned in the lecture. Anyhow, so the beta is going to produce insulin and the alpha is going to produce glucagon. So both of them are going to have an opposite effect. Insulin is going to uptake the glucose by all the cells. So if insulin is going to be, how insulin is being released. So who trigger out, who stimulate the insulin to be released? We already know is the levels of glucose. The levels of glucose, you increase the levels of glucose, insulin is going to be released by the beta cells. They're going to increase the glycogen in muscles, obviously, because if you have more glucose in blood, you use what you need, and the rest is going to be stored as glycogen, especially in the liver and in the muscles. Glucagon is going to be the opposite. In conclusion, if the insulin is bringing in glucose into the cell, glucagon is taking out glucose from the cell. So we have in diabetes mellitus, and in diabetes mellitus, this is something really interesting. Let me see here. Let me check. All right, so well, anyhow, so we have two things. In diabetes type 1 and type 2, we have a problem that is the viscosity. The viscosity is going to slow down, the blood flow. If the blood runs slowly, that is more risk to make a clot. So if you pinch your finger and the blood is on the finger, the blood is not moving for a moment, they start to clot. And that is what is doing the viscosity. It's not stopping completely, but it's going to slow down the blood flow, and that increases the risk for clot, especially at the level of the some atheromas or some blockages on the vessels, where the blood momentaneously is going to slow down and then speed up, but that time is enough in order to produce the clot. Here we have the glycosylation. The glycosylation is very important. Is the other component that is being described since 2004, and that is the glycosylation. What is the glycosylation? The glycosylation is the reaction of the glucose with proteins. Is the reaction of glucose with fats. So glucose are going to react with these elements. Just to go straight, we are going to go into the vessels. We have the vessels, the vessels, we have the endothelium, and the endothelium, they have a strong attachment between cell to cell. Desmosomas, whatever you want to call them, and this glycosylation are going to react with these proteins of the endothelial cells, making this junction between cells to be weaker. So in conclusion, it's like having a tear of the endothelium, and that tear of the endothelium need to be regenerated. They are going to call macrophages, and that are going to be get deposit of cholesterol. So at the end, what we have in the long run in patients with diabetes is that the vessels, all the systems are getting narrow, are going to get narrow. So that means that if you have narrow vessels, you cannot have good blood supply, you cannot have good oxygen, good nutrients. In the long run, one of the tissues that are going to have low blood supply because of this reason, the glycosylation, is the retina. So that's why persons become blind. Or, for example, they have neuritis, some numbness of the nerves. Why? Because the nerves are living organisms, they receive blood supply, and because this glycosylation, they don't receive enough oxygen, the nerves are going to die, and they are going to have this numbness. Another thing is happening with the kidney. In the kidney, the same thing, are going to produce the hardening of the glomerulus, efferent and efferent, and they can lead little by little into kidney failure. So I put this slide because I found interesting here is all these guys, that in dark blue is the one where we have more diabetic patients. Here we have I was surprised. San Francisco is not one. So more darker is going to be, I put it here, Contra Costa, Alameda, Contra Costa, Alameda. So those are the highest. And of course, LA. We have another here in the inner inside of the countryside of the Sacramento of California. Okay, so here we have the three P's: polyuria, polydipsia, polyphagia. Is osmotic diuresis. Osmotic diuresis. You have too much glucose in the urine that the kidney cannot reabsorb. The kidney can reabsorb all the glucose he can, but if there is so much, the glucose starts to escape into the convolute tubules. So it's so concentrated in the convolute tubules that the only way to dilute that is to bring blood from outside of the kidney, and they are going to try to dilute it, equal concentrations in and out. So that produces polyuria. As a consequence, they produce polydipsia. Polydipsia because you're losing a lot of water, a lot of fluid, and polyphagia because the cells cannot receive the glucose into the cell because of the lack of insulin or the resistance of the insulin. All right, so one of the tests that we need to I want to remark here is, first of all, the diagnosis is the clinical presentation, right? Clinical presentation of the three Ps, fasting blood glucose, and what's important is the HbA1c level. What is the HB? HB is the hemoglobin. A1c is a protein level. So what is doing this is to measure the glycosylation. So the glucose are going to react with the protein that is inside the red blood cell, the hemoglobin, and that is going to have a story of 3 months. So they can give you with this lab test a story of your glycemia in the patient for about three months in the past. Normal values of this is less than 6. 7 is already positive for diabetes. Some people, they say 6% or 6 is the same. We have urine glucose test levels, and but this is kind of tricky because not all the time we are going to have glucose in urine. Why? Because the patient is diabetic, is diabetic, and is trying not to, after that, trying not to eat. So the glucose is all gone. So the patient is starting to hypoglycemia, So, and that is, the urine is going to be positive or could be negative. Glucose tolerance to test that test is mostly what we use for pregnancy. When you have diabetic pregnancy, so that is what we use for tests, the glucose tolerance test. After 1 hour or after 2 hours or after 3 hours to take certain amount, 100 grams of sugar, for example. Basically, diabetes, this is not the scope of the course, but basically 95% of the treatment with diabetes is going to be diet. All right, so here we have calcium homeostasis, and the calcium homeostasis is going to be a balance between phosphorus and calcium. So number one, we remember that the bone is formed by calcium phosphates. This is calcium phosphate salts are going to be, calcium phosphates are going to be formed the bone. And if you have excess of calcium, you can lead into the kidneys formation of stones. All right, so what I want just to go here is that there's two hormones, the PTH and the calcitonin. Calcitonin produced by the thyroid gland and PTH produced by the parathyroid gland. So this PTH is going to be released when you have low levels of calcium in blood. What they are doing is to stimulate the PTH is, let me see, calcitonin is going to deposit. and PTH is going to reabsorb. So reabsorb when the levels of calcium are low, they are going to stimulate the osteoclasts, and they are going to have bone reabsorption, and they are going to increase the normal value of calcium. Normal value of calcium is 8.5 to 10 milligrams per deciliter. You know, calcium is going to participate mostly into the neurotransmission, in the smooth muscle contraction, in the skeletal muscle contraction, and in the cardiac muscle contraction. Calcitonin is when you have, is the opposite. When you have an excess, they're going to stimulate the osteoblast, and the osteoblasts make the calcium get into the bone to form the complex, this phosphate calcium. All right, so vitamin D. The vitamin D is called the sunlight vitamin. Well, it's produced by the skin, and there's two sources, skin and diet, right? So this skin and diet vitamin D is a provitamin. It's not active yet. So the vitamin you produce in the skin is not active. The vitamin D that you take from diet is not active yet. So these both vitamins sources are going to go into the liver to have what we call the first hydroxylation in the liver, and they are going to go into the second hydroxylation, where is completely activated the vitamin D just after they pass after the kidney. And the vitamin D is called cholecalciferol. Why? Because the vitamin D is formed from cholesterol. All right, so vitamin deficiencies, we have rickets, osteomalacia, osteoporosis, not bowing legs in the adults, bowing legs in the children, rickets. And actually, we have different situations where you have deficiency of vitamin D, low dietary calcium. Even though if you have high levels of vitamin D, there is no calcium to reabsorb. GI issues like Crohn or CUC, chronic ulcerative colitis, or for example, malabsorption by pancreatitis, etc. Endocrinological issues, lack of physical activity, old age, postmenopausal, corticoids, genetics, and others. Well, anyhow, so that is the end of the webinar today. We finish almost on time. So I want to thank you to all the participants, and I will see you next time. If there is any question, please just let me know.
Thank you very much.
Okay, I'm going to cut it now. Just a moment. Okay, thank you, Joe, for coming. If I cut it, it's gone. So I'm not going, I cannot talk after, it's going to be recorded. Thank you so much. I will see you tomorrow. Muchas gracias.
Thank you.
Thank you.